The last one of the day. We have Carol, Karen, and Ann coming up, and they'll be answering the questions that you've been submitting. And if you notice Carol up here kind of smiling, it's because this is her last full day, I think. She's been responding that I will get back to you on Tuesday about that question, and I had no idea she was retiring on Monday.
Is this on? Yes, it is. Okay. So I'm going to answer some of the questions that came in related to the resources. And the first question that came in is, how do you tell if you're looking at the most current files? And so the response is for quality reporting resources, we retain recent versions on the QRP web pages, and then we archive the others so that they are available for reference. We are working with our counterparts to develop a consistent process for updating the entire manual on a regular basis, and we acknowledge that we update our section of the manual more frequently than other sections. Second question, it would help if you could update effective dates on each section. Very difficult to maintain the entire IRF-PAI manual, exclamation point. Agree, and that's a great suggestion. And as we just mentioned in the prior question, we're working to develop a process so that the entire manual is updated as a whole. So these are great questions. Why does data say unavailable for IRF compared for certain hospitals? And the response is that it could be related to a couple of different reasons. Could be the newness, could be the sample size. So if you have a specific facility or you're from a specific facility and you would like to inquire about this, you should contact the help desk and provide a little more detail, and they can help you. And the final question for this section is, when do you anticipate the IRF-QRP User's Manual version 2.0 and the IRF-QRP technical specs will be updated and posted for the October 2018 changes? And the version 2.0 is posted currently at the bottom of the QRP website. We are in the process of updating the QM User's Manual, and version 3.0 will be posted soon, and we will post an announcement once it comes available.
Okay, great. So Carol and I will be splitting some of the GG questions. Also, there was one question about the APU, and so I did want to address that. So there was questions specifically about the admission pressure ulcer MO300 A through G and their inclusion in the APU determination for completeness. So for pressure ulcer, the discharge pressure ulcer items are used for the measure calculation. The admission items are not used, but I did want to highlight that a patient who is admitted with pressure ulcers and those pressure ulcers being coded on admission are risk adjusters for the functional outcome measures. So the complexity of patients, again, is based on admission, patient status for many items, including pressure ulcers. So if a pressure ulcer present or observed at admission is not coded on the admission section of the MO300, the complexity of the patient wouldn't be reflected in the function outcome measures, just as an example. Moving on to the next question, there were actually a few questions about incomplete stay. So I did want to highlight a couple of things about that. So on the current version of IRF-PAI, so the version that you're currently using now, 1.5, thank you, Carol. If the patient is discharged suddenly to acute care, we've given instructions that you can code the discharge self-care mobility items as 88. So we have had questions, can I code it? We did do an assessment, can I code it 04 or whatever. So you could code it those numbers, but when we calculate the quality measures, the functional outcomes measure exclude patients with incomplete stays. For example, people who are discharged acute. So those numbers don't get incorporated into the quality measure. So it's probably just easier for you to code 88 because the data aren't used for measure calculations. With the October 1, 2018 release, version 2.0 of IRF-PAI, there is a skip pattern that is built in so that if a patient has an incomplete stay, that those discharge self-care and mobility items on the discharge section, you would not be able to enter anything. You don't have to enter anything anymore. And so if you would like to know how the incomplete stay is definition is defined for that purpose, that is in the data submission specifications. Very briefly, that includes people who are discharged to acute care settings, including a short stay acute care, a critical access hospital, inpatient psychiatric facility, or a long-term care hospital. So that's the code's based in 44D, item 44D. If the person, let's say, is discharged to another IRF, so that is also based on item 44D responses. Patients who pass away, so there's an item specifically for that. Patient discharged against medical advice, and a patient with a length of stay of less than 3 days. So again, if you want to know the specifics, please refer to the data submission specifications for that information, but I've given you kind of an idea of what's included. Okay, the next question was also about incomplete stays, and so there was a question about whether patients discharged to hospice, 44D equals 51 or 50, and why that isn't included. So actually this is a really great question because there are several exclusion criteria for the functional outcome measures, one of them being an incomplete stay. There's actually another criteria, which is patients discharged to hospice. So the idea being that if somebody's maybe treatment plan changes because of a diagnosis during the stay, and so the person ends up being discharged to hospice, we may not expect as much functional improvement. So those patients, it's a different rationale in terms of an incomplete stay. And so that's a separate exclusion criteria. So you could certainly code an 88. Those patients wouldn't be included in the functional outcome measure. So coding 88 for that is certainly fine if the person perhaps is in a lot of pain and it's difficult for them to move around in bed or whatever. Let's see. So Carol, I think you're picking up.
Okay. Yep. So we had a question about GG0130 and GG0170 asking if you are gathering information from family or other sources, the info is not documented in the medical record, it asks. And we say that documentation in the medical record should support the data that you place in the IRF-PAI. So the coding that you decide upon really should reflect where the sources of that information came from. Of course, therapists document for the prior functioning and device use. They also document in terms of that information as well. The next question is if the patient performance varies during the 3-day assessment because they are improving functionally with therapy services, should the usual status throughout the 3 days be recorded, or should their baseline status be recorded? If usual and baseline aren't the same, which is recorded? So we had several questions about a usual status and baseline status. So here we stated, all right, it's a long answer, so it's taken up a couple of different times. Okay, baseline function refers to the patient's ability at the time of admission. So basically we want to capture that baseline at the time of the admission and assess the patient as close to that admission time as possible. If the patient performs the activity more than once, determine if there are differences in the patient's performance and the performance, if there are differences in the patient's performance and the performance was a clinical assessment. That's an important key, where the patient was allowed to be as independent as possible and then determine the usual performance. Usual is not the patient's best performance and not the patient's worst performance, as we've been discussing. The admission function scores are to reflect the patient's admission baseline status and are to be based on that assessment. The assessment should occur prior to the patient's benefiting from therapy services in order to capture that patient's true admission baseline status. This is because therapy can, certainly the interventions can affect the patient's functional status, and then the score should reflect the patient's status prior to that patient benefiting from therapy. So another question we had related to usual status was the IRFs collect usual status prior to the benefit of therapy guidelines may require therapy to begin the first assessment of the patient status and not within the assessment time frame. It was questioning, and then of course we said the therapists conduct the assessments prior to developing and implementing a patient's care plan. Another question asked, you state that we are to establish a baseline on admission. This is consistent with determining the burden of care prior to any clinical treatment. Treatment will then impact those scores as the patient responds to skilled intervention. So we answered yes, the patient's baseline is as close to admission as possible and before therapeutic intervention is taken place. Another question was if a patient only performed an activity twice in the last 3 days of their stay, how should we determine which code to use if the patient performed differently on each occurrence? So we said and discussed about the anticipation that a multidisciplinary team of clinicians is involved in assessing the patient during that 3-day assessment period. So of course, by interviewing your staff, the direct care staff especially, additional information can be available to add that information that's necessary from observing the patient, and then of course use your clinical judgment to determine which code is to be used to the best of your ability. For example, if there are differences, determine if the patient was allowed to be independent as possible, so that you can take that information and weigh it towards what you decide in terms of the code. Another question asked, we currently use code 09 for GG0130F, which is upper body dressing, when street clothes are not available. Will it now be more appropriate to use code 10 in this situation? So regarding version 2.0, that's coming out that you'll begin to use October 2018. First attempt to procure patient or practice clothing should be attempted. Some facilities have stated that they use surgical scrubs as practice clothing for assessment use. It should be rare, but it is acceptable to code 10. Again, this is for version 2.0. Not attempted due to environmental limitations if the patient did not attempt this activity due to clothing not being available. But most facilities seem to have some reserves in terms of clothing in the event that the patient does not have clothing, or as we said, the medical scrubs. So on discharge goals, a question asked, is a dash the same as leaving the item blank, or is a dash required? So we note that use of a dash is permissible for any of the remaining self-care or mobility goals that were not coded. Using the dash in this allowed instance after the coding of at least one discharge goal for the self-care or mobility items, so at least one, does not, then use of the dash will not affect the APU determination. So data submission specifications require a response. Next question is, if the patient is unable to safely complete a function activity on days 1 and 2, but is able to complete the activity with moderate assistance on day 3, would the correct code be 88 because that was the usual performance and closest to the admission and baseline, or code 3? While we state in the assessment coding that the assessment coding should be completed as close to the admission as possible, we do recognize that it may be not possible always to, due to the patient's medical conditions, to do it as soon as the patient upon admission. So if the patient is able to complete an activity, as in your scenario, on the 3rd day, then you would code the patient's performance based on the amount of assistance needed by the patient, as long as the patient did not benefit from therapeutic intervention. And if therapeutic intervention had taken place prior to your assessment, then you would use code 88, not attempted, due to medical condition or safety concerns. Another question was, if a therapist assesses at baseline that a patient cannot complete an activity, so they code 88. However, once they receive therapeutic intervention within the first 3 days, the patient can complete the activity. Do we still keep the score as 88, even though they completed the activity in the first 3 days? So we answered that once a patient has been assessed as unable to complete an activity and then receives therapeutic intervention, the patient may have benefited from that therapeutic activity, and in this scenario, the initial assessment coding of 88 would be retained. So another question asks us to further explain the dash, and asking if the person was allowed to only provide 1 goal per section, but as required to place a dash, and misinterpreted this, that they were required to place a dash for every other goal. And then it was asked, is that the only instance that you would use a dash? So we reiterated that a minimum of 1 self-care or mobility discharge goal must be coded, but we say, however, facilities may choose to complete more than 1 self-care and mobility discharge goal. Code the patient's discharge goals using the 6-point scale, and of course, use of the activity not attempted. Codes 0, 7, 0, 9, 10, and 88 is permissible beginning for version 2.0, October 2018. And use of a dash is permissible for any remaining self-care mobility goals that were not coded. Using the dash in this allowable instance after the coding of at least 1 goal does not affect APU determination. So that the dash rule is effective now, and it's also effective for version 2.0 in October 2018. It's the use of the activity not attempted codes for discharge goals that distinguishes between what you're doing now with the version 1.5 and then version 2.0. Another question was, where does a catheter fall under toileting hygiene? So we answered, if the patient has an indwelling urinary catheter and has bowel movements, code the toileting hygiene item based on the amount of assistance needed by the patient when moving his or her bowels. And remember that toileting hygiene has those several items or several tasks that are part of that activity of managing the clothes before, then doing the hygiene, and then afterwards managing the clothes. So keep that in mind. Does dressing include gathering clothes? So we answered, if a patient requires the assistance of a helper only to retrieve clothing, then code, in this case, upper body dressing or lower body dressing as 05 setup or cleanup assistance. The rationale here is that the helper sets up the activity, but the patient completes the entire activity. So another question asks, what kind of supporting documentation is CMS expecting that would support the code chosen for each of the quality indicators? So we always say that documentation in the medical record, which may include clinical notes is used to support assessment coding of the section GG. Data entered should be consistent with the clinical assessment documentation in the patient's medical records. This assessment can be conducted by appropriate healthcare personnel as defined by your facility policy and in accordance with state and federal regulations. So the next question was the, let's see, that was LTEC data. Here's that, so we're going to skip that. Will the slides referring to the rationale for the coding be available on the website? And we had several other questions regarding the materials that were used, because when we provided you initially with those materials, it didn't indicate what the answer was in terms of the scenarios, and those will be up on the CMS website. Currently, there's several things that are up on the website for the QRP IRF program, and that is all the materials that you had here today, which would include the slides, but again, there will be the additional slides that will show the coding answers, and then soon after that will be the questions and answers that you had submitted. So we will be submitting, and those will be posted on the website as well. Last one I'm going to do and then turn it over to Ann is a common complaint. Showers are usually completed during the evening night shift by nursing. The therapists normally do not see the 11 p.m. to 7 a.m. shift to discuss the patient performance. This is also a problem over the weekend. Staff not available to full-time staff to discuss the patient performance. So the way that we answered this was that, provider policies may include a means of communication, you could ask about that, between care staff to inform patient performance in order to provide information necessary to inform the coding of the patient's performance. So I'm going to pass the mic to Ann.
Okay. Great. So there was a question basically about lifting overall, and it talks about whether lifting one leg versus two leg or body lifting makes a difference. So I guess the bottom line, they said lifting of any type is either 3 or 4 based on level of assistance, and that is correct. So if there is lifting assistance that is happening, it will be level 3 or below. And level 4 is focused on touching, contact guard, supervision. Next question, what if there is only one person during a mechanical lift to complete a sit-to-stand with the patient completing little, if any, effort? So here, if there's only one person helping, you would basically follow the decision tree. If the patient is doing a bit of the effort, the patient, in this instance, the code would be level 2. If the patient was not providing any effort and the helper was using the device and doing all the effort, the code would be 1. The next question somebody asked is about whether the decision tree would be available. So currently it's only available on the slides, but we will look into getting that incorporated into other materials. So appreciate the feedback on that, and it looks like a few people like that one. So thank you for that feedback. The next question, for lying to sitting, if your patient is short or they're unable to touch the feet of the floor with the bed fully lowered, can this still be scored based on level of assistance required? So in this case, we'd say use your clinical judgment. If the person is completing the activity or if a stool needs to be brought, that might be considered setup assistance. So again, use your clinical judgment and think about what the person's going to be doing at home. Next question. For car transfers is only completed, if car transfer is only completed getting into the car, can this be coded with how much assistance the patient needed? So, so the item is really about getting into and out of a car, so we would expect an assessment to include both of those. Certainly somebody might need more help getting out of the car than getting in the car, and so it should be coded based on getting in and out of the car. And if only one is able to be assessed, then you would use clinical judgment to determine if you can code that. The next question is, can we use the updated coding examples in the updated IRF-PAI manual for items on the current IRF-PAI? So I wanted to clarify that we created new examples for this training. So what you heard today, again, very much inspired by questions you've submitted. Those responses would be the same now or for October 1, 2018. Many of the I think pretty much all the examples that were in the IRF-PAI previously are still in the IRF-PAI with the same responses. When we updated the terminology, the definitions, it really doesn't affect coding. It was just meant to clarify, make sure that you have, for example, as you look at the IRF-PAI, liquids is actually listed as part of eating. So it wasn't there before. It was always supposed to be considered, and based on the feedback we got through help desk questions, we said, okay, we should make sure that's on the data set so people can use it and are coding consistently. So from the standpoint, can you use these new examples? Absolutely. You can use them now. You can use them for talking about October 1, 2018. Obviously, the code 10 is new, October 1, 2018. As Carol mentioned, for goals, you can now put the activity not attempted code as goals. So those are coding things that only can be applied to October 1, 2018, patient's discharge. But in terms of the answers that we gave today, they are certainly still true today and past October 1. Okay. And I did want to also highlight that we added many of the things that I talked about from the examples. We added coding tips into the manual. So for example, when I talked about the wheelchair and the transport, there's coding tips about that. There's coding tips about eating. I think there's coding tips for just about every item. And those have been added not only to the IRF manual, but also the LTAC manual and the SNF manual. Let's see, next question. So there were a couple of questions where, let's see, we have a standard car at our facility that we use for car transfers. If someone uses it at admission and scores 3 partial, and then at discharge scores 4 supervision in that car, but has a truck to travel with, and during the family training scores 2, how do we code it? So ideally, you should be assessing patients on what's going to be relevant for them in terms of their discharge situation, whether it's clothes or the type of vehicle. So obviously, we leave some clinical judgment to you in terms of how that actually plays out. But, if somebody's going to be discharged and they need to get in and out of a truck, it would be nice for them to be assessed on and practice that during the stay if that's possible and the family's able to bring in the truck. Next question, admission function scores are to reflect the patient's baseline status prior to any benefit from therapeutic intervention. If therapeutic intervention includes introducing a new device for ambulation, how would you rate admission walking? So if a patient is being assessed on admission and they've been using a device prior to admission, definitely assess them with that device. If the device is new and it's a fairly simple device that kind of a layperson could give instructions and the person can be assessed with that on, let's say, when they're getting initial therapy, that's fine to do an assessment with that. If complex instructions are required, that does seem like therapeutic intervention, and so in that case we would say that the patient could not perform the activity prior to getting intervention and benefiting from therapy. So I know there's going to be some clinical judgment there, but again, the intent is what is the patient's status when they enter into your inpatient rehab facility program, and so that we can again document improvement that they received based on therapeutic intervention. Another question, actually a great question, can a floor mat, yoga mat be considered uneven surface? It certainly could be. The definition talks about indoor or outdoor uneven surface, and if clinical judgment is determined that that's a way to do it, certainly that's fine. Another question is if the patient requires a tilt-in-place chair and is unable to propel. Okay, so sorry. The person has a specialized wheelchair at home and they're not able to bring it into the facility. How would that be coded? So I think we're going to get back to you on that one. So when the questions get posted, as Carol described, we'll get back to you on a response on that one. There were a couple of questions about stairs. I think we're running out of time here. So there were a couple of questions about risk adjusters and whether the primary diagnosis is risk adjuster. Yes, the person made the case that it should be. It is. And so maybe I think we'll stop there. And again, we will have answers to these questions posted on the website so you can see all the answers in writing in the near future. So thank you very much. Appreciate you staying all the way to the end. And